Exactly right. It is a survey study specifically trying to understand this idea of how do we screen for financial concerns or for financial toxicity. Our group had done some prior work looking at what was out there in terms of financial instruments, in terms of what other people are doing for financial screening. And with our systematic review, we showed that there's just wide heterogeneity. There's no consensus on how often to screen, there's no consensus on instruments, there's actually no guidance on what we should be doing. So we wanted to actually ask patients what they wanted. How often do they want us asking them these types of questions? Were they ever asked these types of questions by their care team? We partnered with a wonderful organization called the Pink Fund, which is a nationwide breast cancer specific philanthropic organization that actually aimed to offset financial toxicity by providing funding for patients who are actively undergoing breast cancer treatment. They fielded this survey electronically, and like you said, we had over 700 respondents. We really focused on tangible questions that we can put into practice. How often do you want to be screened for your financial concerns? Do you want to initiate these conversations, or do you want your providers to initiate these conversations? And when in your treatment course do you want these types of concerns to be brought up? After you've already decided what kind of treatment, or even before? And we were actually able to show that patients want financial screening to happen really early in their treatment course, either right when they're first diagnosed or as soon as they decide what kind of treatment they will be undergoing. They really wanted their providers to be the ones to actually initiate these conversations, to bring it up first so that they could feel comfortable to then respond. And they wanted it extremely often. So either once a month or every single appointment when they were coming in and interacting with their providers. So this is very different than what we've actually been doing in the United States. So if you look sort of at all the published literature, most of our screening is done at one single time point or maybe twice. It's not something that we do longitudinally, and it's also not something that we integrate very early on. So these patient voices can really tell us how we should start changing and what we should start doing differently to be able to incorporate patient voices better. You're absolutely right that we weren't able to delve into that more deeply in our study, but just drawing on prior literature and also just clinical experience, when you're thinking about how equipped providers actually are to be able to hold these conversations and actually help patients, much of the literature shows that providers, physicians in particular, are actually really poorly equipped to have these types of difficult conversations with our patients. We don't necessarily know what resources to point them to. They'll ask us a question about how much something is going to cost or what their out-of-pocket costs might be. And many of us just kind of throw up our hands and say, "I'm not sure, we'll have to call someone else." And a lot of literature or sort of research studies in financial toxicity is actually looking at that, improving these types of provider-facing conversations, or even some work looking at actually training physicians to be able to do a better job at fielding patient questions. So that's one aspect of it, is that we're just not equipped as physicians and we're not trained how to have these conversations. The second thing, so for me, this idea of bringing up financial concerns really early on when someone is first diagnosed, it's actually, it replicates another finding that we had in a similar study where we had actually interviewed breast cancer patients and asked them some questions and got some qualitative responses. And in that prior study, which we published a couple years ago, this idea of wanting to have these conversations really early was actually the most surprising finding for me. Because as a clinician, when I'm going in and I'm talking to people, so the radiation oncologist going in, I'm talking to them about the literature, I'm talking to them about the data, I'm asking them to make decisions, I'm going through all the side effects of treatment as well. And most patients are just not able to sort of even take in all of that. And then you're asking us to add on a whole separate layer of the conversation. As a provider, it is something that I really struggle with in terms of how do we do this in a way that doesn't overwhelm patients. So utilizing some of our ancillary providers, like our social workers or patient navigators, who are able to connect with patients at a different time point or in a separate sort of conversation after they've had some difficult conversation with their providers, potentially allows patients a little bit more in time to process, a little bit more time to kind of separate this idea of treatment versus implications. So I like that sort of side of it. But I think what patients are getting at with this is my providers are not equipped to actually have the conversation with me. They're overwhelming me with all this other information. And on top of that, I think I just need to have the conversation with someone else, is my suspicion, but it's something that we're very interested in exploring further.